Hello, everybody. Welcome to today's webinar of the Gerhard Center webinar series, The Aftermath of COVID-19 to the New Social Impact Ecosystem. Today, we have two great speakers from the Fred Hollows Foundation, an international development organization working in more than 25 countries to end avoidable blindness. The foundation has restored sight to more than 2.5 million people around the world. The foundation's vision is to deliver a world in which no person is needlessly blind or vision impaired. We have two speakers today. Dr. Andrew Cassels-Brown is the medical director at the foundation, the Fred Hollows Foundation. In his role, he's responsible for driving medical advice, research, and innovation that will extend the foundation impact. He brings 3 decades of ophthalmic experience and passion for community eye health and sustainability. Dr. Yeneneh Deneke is the medical advisor for Africa and Middle East at the Fred Hollows Foundation. In his role, he's responsible for providing strategic leadership on medical and technical areas to ensure delivering greater impact in addressing blindness. I mean, I cannot stress how important it is to sort of eradicate needless blindness. When you look at the statistics, and the two gentlemen will talk more about this, you can see right away that there is inequality there. I mean, the poor are more impacted by this. Now imagine if a poor person is visually impaired. That's definitely going to impact his ability to sort of to earn a living. Without much ado, I'm looking for a very insightful conversation around restoring sight and its impact and the lessons learned. And I pass it to Andy. Andy, the floor is yours, sir.
Thank you very much indeed, Professor Ali. Really appreciate the introduction. I'm very pleased to be here with you all in today's webinar. Very nice introduction too, and a summary of the foundation work. You've done half my job for me, so that's great. Thank you very much. So you can see the title of the talk today, and particularly the COVID impact and what the Fred Hollows Foundation is trying to do will be covered by my colleague, Dr. Yeneneh. So as Dr. Ali says, that who we are and what do we do, and he's already prefaced the fact that Fred Hollows himself was a very iconic and famous ophthalmologist who spent most of his life working in Australia, but he also did a lot of work in many of the countries that the Fred Hollows Foundation serves and supports today, and including, and unusually, in Australia, he was very much an early pioneer of prevention of blindness in the Australian Indigenous, Aboriginal and Torres Strait Island population. So Australia, where the charity is predominantly based, has its own internal challenges which are shared by many low and middle income settings. So I think that's a very important perspective for us to bear in mind, and rather unusual one compared to most other international NGOs. So I'm going to just give you a little introduction and overview of the main causes of blindness, some of which you will be familiar with. And then we'll talk about the numbers and the epidemiology and the very scary dramatic increase in blindness and vision impairment that we're all globally having to manage. So the first and foremost is cataract, which many of us will be familiar with as clouding of the lens. And the cataract surgery, it can often be done within 20 minutes and can actually be performed with just $25 US. So it's a very cost-effective intervention which has dramatic improvements on people's qualities of life. One of the things that we'll be talking about is the gender inequity that exists globally for many conditions, but certainly for visual impairment and blindness. So, for example, globally, men are 1.7 times more likely to be able to access cataract surgery than women, even though the women share more than their fair share of the total blindness. And in some countries, men and women actually seem to have the same access to the cataract surgical rate, but despite this, there's still another up to 50% backlog of cataract blind women who never get surgery. So this is a very sorry state of affairs. And Fred Hollow's foundation has really been the only international NGO that has supported the development and continues to support the production of quality, affordable intraocular lens factories in Africa and Asia. And they're based in Africa, they're based in Eritrea, and in Asia, they're based in Nepal. And the second leading cause of blindness and visual impairment is a new one for the Fred Hollows Foundation to be targeting in its current strategy, and that's the issue of uncorrected refractive errors. And you'll see here a child that has got glasses, but unfortunately there are many children who don't get access to simple life-changing optical correction, either for their increasing myopia in Asia or after cataract surgery, which can make a massive difference to the final quality. Trachoma is the world's leading infectious cause of blindness, still very much a global public health challenge, despite all the work that everybody's been working on. So it's a neglected tropical disease. And you'll see this lady here from Ethiopia. She's actually had lower eyelid surgery, which is a bit unusual. The definition of trachoma by WHO is actually upper lid interning eyelid. And you can see that there are 182 million people at risk of trachoma, and with a massive productivity loss of $8 billion US. But bear in mind that these $8 billion are the loss of productivity is for those populations for whom a dollar means an awful lot more than perhaps to some of us attending the webinar. Again, women are 4 times as likely as men to be blinded by trachoma. It is very much predominantly a mother and child disease. So there's lots of environmental sanitation issues that need to be addressed. So it's quite a complex solution, and Fred Hollows Foundation is a major player with the International Trachoma Coalition and initiatives to try and eradicate this. And a large proportion of this, as she is present in Ethiopia, where Dr. Yeneneh is based in Addis Ababa. Diabetic retinopathy is another major rising global epidemic, as is the epidemic of diabetes naturally. And in high income settings, this is actually the leading cause of blindness in the working age population. But the lower and middle income countries, unfortunately, are not spared from this. And there's also a rising epidemic and a tide of blindness in this as well. And I thought, whilst we've looked at the cataract, which is the lens inside the eye, we've looked at spectacle, uncorrected refractive error that is in front of the eye, and we've looked at trachoma, which causes corneal blindness. The cornea is the transparent window into the eye. We're now looking at the retina, and this is the typical of advanced diabetic retinopathy, which has not been adequately detected early enough and has not had adequate management. So the slide on the bottom left shows these retinal hemorrhages, and these white flecks are hard exudate, which is where serum proteins are exudating through damaged blood vessels caused by the diabetes. And on the right-hand side, you can start to see that there's new blood vessels growing inside the eye, and they hemorrhage, and you can end up with an eye full of blood. So you can also see some scars there on that bottom right-hand slide above the retinal vessels there, which show laser burns as well. So laser and intraocular injections are one of the mainstays for that. So all of these conditions and glaucoma and age-related macular degeneration all add up to, the figures that we've been working on to date are that 36 million people are blind. This is the definition is, WHO is on the vision chart, it's what we call less than 3/60. So in other words, they can't see with both eyes open the biggest letter on the top of the sight test chart when they're standing there at 3 meters. So not everybody who's classified as blind is completely blind in both eyes, but there are also a lot of other people who suffer low and moderate and severe levels of vision impairment who are not quite classifiable or definable as blind. And we'll come on to look at that. A lot of that is refractive error, uncorrected refractive error. And 4 out of 5 people who are blind and vision impaired really don't need to be. And I'm afraid 90% of the burden of the world is in low and middle income sectors. So let's have a little bit look at the numbers game. So where are we here in the year 2020? Particularly after the World Health Organization's Vision 2020, the Right to Sight Global Public Health Program, which kicked off in around about 2000. And here we are in 2020. And unfortunately, despite the fact that we've learned a lot of lessons and we've done a lot of good, there is still a dramatic increasing prevalence of blindness and vision impairment. And that's largely due to the rapid increase in global population size, and in particular in the aging population. So many of the non-communicable diseases, as many of the participants will know, are much more prevalent in aging populations. But again, where you've got increasing populations, particularly in Asia with their increasing myopia, these are major problems. So, and in the high income settings like the UK, we've done our own UK-wide modelling, and we predict that there is going to be a 50% increase in demand and need for age-related macular degeneration, cataract, glaucoma, and diabetic retinopathy services in the next 10 years. So these are very, very pressing global epidemics, really. And the picture on the right shows in these increasing circles how the total number of people who are blind and with moderately severe visual impairment has been gradually increasing over the last 20 years, despite our best efforts. But the most scary slides images are on the bottom, the 2 circles. The bottom one shows that in 2020, we've got 276 billion people who are either blind or moderately severely visually impaired. But by 2050, that number has almost tripled. So that there's a lot of work for us to be doing. So we're now in the 2020, after the Vision 2020 WHO Global Right to Sight initiative. Where are we? That's where we've come from, and where are we going now? So fortunately, not surprisingly, the WHO has released last year its World Report on Vision, and its implementing partners globally are a peak body called the International Agency for the Prevention of Blindness. So in a way, they are the provider arm for WHO. And the World Report on Vision has made good progress in making eye care an integral part of universal health coverage, because hitherto we found it very difficult to get into national health plans. And we also know there are lots of barriers to our beneficiaries from gaining access to the service. So there's a very big focus on developing integrated, people-centered eye care in the health systems. And we also know that sometimes the quality hasn't been quite good enough to want our public and communities to come forward for this. So promoting high quality implementation and health systems with research, getting the evidence which really shows us what works well, monitoring the trends and evaluating progress. And the other big factor in the World Report on Vision is really we need to be mobilizing awareness and engagement and empowering our communities. And Dr. Yeneneh will come on to that a little bit. Because this is also set against the backdrop of climate change and the Sustainability Development Goals. Many of us will be familiar with these, but it is another almost more pressing global public health priority. It is the top global public health priority. My sources say that although the Paris Agreement said that we would try and limit global warming to 2 degrees by the year 2050, I think the reality is that unless we can do this by 1.5 degrees by 2030, then we will have missed the boat. Healthcare is responsible for some of these 2 billion tons of CO2 equivalents annually, and accounts for nearly 5% of global greenhouse emissions. So we need to get our own house in order. High-income countries are often the worst emitters and are often the worst users of plastics and things which we're all very familiar. And low and middle income countries have also got their own contributions, but particularly need to be focusing on environmentally safe waste management systems. And the World Bank estimates that that by 2030, another 300 million people will have been pushed into extreme poverty, which are through climate change issues, and this affects everything that we know and think about. And the healthcare systems themselves will be ravaged by extreme weather and climate events and resource depletion. And I think that the COVID-19 pandemic is a really good example of how we are totally been unprepared for being sustainable going forward. And it really is providing major problems, as you know. And the climate change itself will actually increase prevalence of certain blinding conditions, for example, trachoma and vitamin A deficiency, which we were hoping to have eradicated, but it's likely to, this is a cause of childhood blindness. And this is why the Foundation made it a strategic priority for our 2019-23 strategy. So what is the Foundation doing about it? Well, the Foundation feels this is such an important issue that our Sustainability Working Group is actually led by our CEO, Ian Wishart. And in addition to all the usual internal carbon footprint assessments, we've developed the green teams, and the country teams and partners are increasingly sensitized with advocacy, etc. And the Foundation actually funded or co-funded and facilitated the IAPB Climate Action Working Group workshops in Dar es Salaam in November last year. And the Foundation has also commissioned and supported the IAPB Climate Action Working Group to produce 3 documents: a call to action for all the IAPB members, a proposal for declaration of a state of climate change emergency, and also a more expansive guide to sustainable eye health care, with a very good forward in that document from the IAPB CEO. And I presented these on behalf of the IAPB Climate Group to their board last week. The Foundation specifically is supporting things like partners' waste management programs, for example, in the poor. And the Foundation is also using eye efficiency, which was primed by the Standard Chartered Bank. And this is the world's first healthcare carbon footprinting app. We're piloting this in our cataract programs for the first time globally. So I'm now going to hand over to my colleague, Dr. Yeneneh, who actually will give you real life experiences from the areas that he covers in East Africa and the Middle East. So Dr. Yeneneh, please carry on. Thank you.
Thanks, Dr. Andy. Thanks, Ali, and everyone. Greetings from Addis. Nice to know you, all of you, virtually. I'll be presenting 2 topics briefly. The first one is the impact of COVID-19 on eye health, and the second one is strengthening eye health. You know, before looking into the effect of COVID on eye health, I think it is worth to describe the situation of eye health pre-COVID. Then what's happening during this COVID stage, then what do we anticipate the post-COVID. You know, a pre-COVID era, eye health already suffers from poor healthcare system and low demand. By this, I mean there is poor health system in terms of human resource for eye health. There is low number in resource-limited countries, like in Ethiopia. For over 110 million people, there are less than 200 ophthalmologists, maybe 160 or so. The situation is a bit different in Egypt. I think Egypt has close to 3,000 ophthalmologists by any measure. This is a very good number. The other challenge on this HR is unevenly distributed ophthalmologists. As you know, most are working in big cities and towns, and some of them are not clinically practicing. The productivity is often poor. That means surgeons are operating only a few cases, and some of them are not really motivated. The other challenge is poor infrastructure and supplies. There are not enough primary, secondary, and tertiary care facilities, and there is extreme shortage of equipment and supplies. Government also not doing enough, not providing adequate resource, because you know the government in resource-limited countries are fighting with killer diseases like TB, HIV, malaria, diarrhea, and so on. So the other challenge is on the demand side. You know, even when the supply side is good and when the government and the facilities are good, then there is poor demand due to low awareness of eye care by the public, and by the government as well. This can be exemplified, like the cataract surgery. Cataract is the leading cause of blindness, as Andy stated earlier. The cataract surgical rate, which is the number of cataract surgery done per year per million population, in most of sub-Saharan African countries, ranges from 500 to 700. And with a developing nation or an emerging economy like India, has reached to 6,000. You can see the difference over tenfold. So during COVID caused health crisis and eye care at all levels. The effect of COVID is multidimensional. It affects the social, the economic, and health as well. Like health mean HIV, cancer, and other chronic patients are rising. And COVID affected eye care at all levels. That means the primary, secondary, and tertiary eye care in Africa and Middle East. So eye care has been on hold, and MDA, Mass Drug Administration for trachoma, has been on hold for the past 6-7 months. So COVID has really hit eye care very hard. No eye care activity has been carried out for the past 6 to 7 months. It has been a great challenge. So our team were redirected their effort to help to fight the virus, and some of the funds were repurposed for taking care of the virus. Clinical and surgical outputs are dramatically reduced, and the backlog of cataract and TT surgery has risen because of that. Next slide, please. So restart of service in COVID, FHF developed position papers, risk assessment, and so on. Most of the communities are desperately seeking for restart of eye care since there was no service for the past 7-8 months. The foundation has come up with a number of relevant clinical guidelines, checklists, protocols on a safe start for regular eye care service and trachoma control as well in the midst of this COVID. So technical support has been given for the comprehensive eye care, including cataract, diabetic care, glaucoma, and other diseases, and mass drug administration for trachoma surgery, eye health surveys, and so on. So the foundation has been supporting African and some of the Middle East countries like Eritrea, Ethiopia, Kenya, Rwanda, Pakistan, Palestine, and Afghanistan. Next, please. So moving on this, FHF supported a number of African and Middle East countries, as I said earlier. It has provided the necessary technical support through the medical advisor. And the team has produced mass awareness tools, leaflets, and posters in line with national messaging. We have resourced and supplied adequate PPE or personal protective equipment like masks, gloves, shields, and so on to government partners. After that, Eritrea, has now already started the treatment of trachoma with azithromycin or Zitromax. One zone has been treated. Ethiopia, Kenya, Rwanda, and the countries I mentioned in the Middle East are on pipeline. This COVID was not only a challenge, but it was an opportunity for some innovative solutions. So the foundation has been supporting some tele-ophthalmology and telephone consultations. With this regard, we are working with country teams on innovative platforms for screening of diabetic retinopathy and other eye diseases. So the last question on this COVID situation is, what is going to happen now once COVID is over? We anticipate more challenge for eye health in the foreseeable future due to the COVID, since the government facing economic challenge. Every government is now strained with a lot of economic challenges. Eye health in resource-limited countries like in Ethiopia, Kenya, Rwanda, Pakistan, Palestine, and other Middle East and African countries are dependent on external funding. Most of the eye cares are funded by, various NGOs, foundations, and so on. And we are seeing some clues that, funding environment and external support could be shrinking a little bit hereafter. So we anticipate some challenge on that. That's all about COVID. We can have more discussion when the time comes for that. Strengthening eye health, eyeballs are small, as all of us know, but no organ in the body is as complicated as the eyeball, though it is very small. If you take 1 centimeter by 1 centimeter and take a cross section and study it, it is the most complicated organ in the body. It's like eye is an extension of the brain. So, but eye health does not get required or the attention it deserves in terms of funding and messaging, even from the government. Luckily, recently, WHO endorsed cataract surgery, which is the leading cause of blindness, especially in the developing nations, as one of the top 20 global universal health interventions. Next, please. So what is the foundation approach on this regard? Our approach is health system strengthening. There are some components on that. First, we work on leadership and governance. We support the government various partners, for greater ownership of local Ministry of Health, including the regional, national, zonal, and so on. We have been part of National Committee for Prevention of Blindness, supporting blindness survey, and so on. And we support the government through technical and financially to develop national policies, eye care policies, guidelines, and critical protocols, including, on the quality aspects, trachoma, cataract, and other very important clinical guidelines has been supported by the foundation. The other challenge, as I stated earlier, was equipment and supplies. The equipment and supplies required for eye care is not readily available in the local market because, the business people does not really dare to import those instruments because of low mobility. So it's not a fast-moving item. So we have been providing a range of equipment. Eye care is equipment-intensive field. We have been providing eye care equipment and supplies for the government facilities. The other challenge in the eye care is health information. We don't, data, we need strong data for action, so information for action, but in resource-limited countries, there is extreme challenge on health management information system, and we have been supporting the government on this line, and situations are really changing. Next, please. So the other aspect, as I said earlier, the challenge is human resource for eye health. The Fred Ollos Foundation have trained over 100,000 doctors, nurses, primary eye care workers, and so on. For instance, in Ethiopia alone, we have trained over 300 nurses, trained and equipped, not only training and sending them home, but they were also equipped to carry out trachoma surgery, and they are doing a very good surgery that was substantiated by study. Thousands and thousands of primary health workers trained for trachoma drug distribution. So you cannot dare to distribute Zitromax or trachoma drug for 20 million people by health workers. We don't have that capacity, so we need to train the primary eye care workers. In Kenya, ophthalmic officers were trained to provide advanced diabetic care. That means screening of diabetes through using cameras and so on, and intraocular injections to treat that. And the foundation has also supported Eritrean and Rwandan doctors on residency program in Kigali and Nepal. The other aspect is service delivery, as we mentioned, as Dr. Andy raised earlier. We are working to increase access to the needy community, rural poor, to benefit the rural poor through outreach. Women are, disproportionately affected, disabled, and other marginalized groups. We are also working to improve referral system, two-way referral system from primary to secondary, from secondary to tertiary, and vice versa. So the foundation is focusing on the leading cause of blindness and low vision. These are cataract, trachoma in countries like Ethiopia, South Sudan, and so on. So trachoma is a leading cause. There is high proportion of trachoma in Kenya as well. Refractive errors is very rampant. Diabetic retinopathy also coming into the pictures. You know, people think that diabetic retinopathy is a problem of the rich countries, but that is no more true. We have been hardly hit by that. So people say we have now a double burden. We are stricken by communicable disease and at the same time by non-communicable disease like diabetic retinopathy. Next, probably the last slide. Yeah, this is the woman health care worker. You know, as you can see, she is educating from a picture from Bangladesh. She's a woman health worker carrying out high health education. So the foundation is working towards empowering women organization to, to address the inequity. So thank you very much for your attention. I will give the floor for Professor Ali.
Thank you, Andy. Thank you, Andy. Thank you, Yeneneh. Very, very eye-opener and lots of heavy dose of information. Let me. You've mentioned ophthalmology. How much could you do remotely? I mean, the major question for me actually is COVID-19. Is it going to change the delivery mechanism of your services on the long run? And if that's the case, how?
Perhaps I could take that from a global perspective initially. The answer is yes. And again, it's a dangerous thing to say, but of course there is a silver lining with having a pandemic, because it does force us to look at transforming our eye care delivery pathways. So yes, we want to restart, but one could go with the mantra, no restart without transformation. And for example, the example that Dr. Yeneneh gave around using teleophthalmology is a really fantastic benefit in many ways. Not only does it provide a service very much in the community, in the local primary care center or vision center, but it also reduces, it speeds up and gives them better access to secondary and tertiary care specialist support. It gives them access on the same day to that as well, so they don't have to travel to a secondary care unit. And there's costs involved, not just for the individual patient, the direct costs, but there's also the indirect costs of all the people who will often have to travel with to support their family member, particularly if they're visually impaired or blind. And of course, all those things also can help us deliver service at a much lower cost, but also at a much lower carbon footprint. So I think there's a real opportunity to be gained from not going back to business as usual. It's building back better is the slogan that we like to use in the foundation.
Okay. Yeneneh, do you want to add anything to this?
No.
Okay. Now, when you were talking about cataract operation, I couldn't help but draw a comparison with the Indian famous case, the Arvind Eye Care Center. I mean, Arvind has done two parts. There is an operational innovation, the way he does the operation. He does it basically at a mass scale. So it's more like an assembly operation, actually. This is one. The other thing which is interesting, and you've discussed it, the major part of the component of the cost are the lenses. So they actually produce the lenses. And I think you've mentioned that you produce the lenses in Eritrea or Nepal, right?
Yeah.
But anyway, my point, what I'm getting at, is that you have to produce more or less, maybe more, with much less resources. So there are two venues you'll have to address. The first venue is operational efficiency. You have to be able to do things in a better way, cheaper. This is one. The other part is visibility and marketing. And technical people are not the best, excuse my English, and in terms of marketing and visibility. I'm talking about you have to convey to people who are actually having the money the value of what you're doing. So they continue giving you money, because there will be a perception that a TB or a cancer is more important than saving the vision of somebody at the base of the pyramid, which is probably far from the truth.
Can I address that? And I think Dr. Yeneneh has probably got a very good example of Aravind and just starting to work with Ethiopia. But first of all, Fred Hollows has worked very closely with Aravind Eye Care System and also with LV Prasad and quite a few other global partners. In fact, Fred Hollows has recently created a social enterprise model with its first hospital for Alina Vision is the social enterprise arm of Fred Hollows, and its first hospital is in Hanoi in Vietnam, and moving forward to again work with Nepal, where the IOL factory is based. So the whole cost recovery mechanisms and the whole increasing in productivity, but also doing that at the same time of having it at a more affordable cost and also lowering carbon footprint is a very close relationship that we have with Aravind, partly through our new social enterprise provider arm. But Dr. Yeneneh, do you want to just discuss what Aravind have been starting to work with Ethiopia, please?
Yeah, initially, Aravind is, as Professor Ali said, they are the most efficient probably in the world. They are carrying out over 500,000 surgeries with their satellite clinics. They have set up a very great cost-tier system. Some those who can afford can pay, and the others will be operated for free, but with same quality surgery. And there is a good screening mechanism at their satellite clinic, and patients are referred to the center. So they are carrying out a massive surgery. They have their own intraocular lens factory, not only intraocular lens, but they produce also the very required supplies and consumables like viscoelastic fluid, drugs, drops, different fluids and so on that are required. So their system is like through linking the primary eye care to the secondary eye care and even to the tertiary eye care. Even their diabetic retina program is, the primary eye care workers take a picture from the field and they send it to through the tele-ophthalmology to the center, and the ophthalmologists review and send back what has to be done to that patient. So it's a very organized and a very exemplary center. They are initiating some establishment of a vision center in Ethiopia. Probably this will be coming in the coming few months, that we could be collaborate with them to establish primary eye care. Their focus is on the primary eye care, where most patients are seen, and they link to the tertiary and the secondary eye care facility, where the patient get operative services and other services.
Okay, I'm gonna take some questions from the audience, and I'm gonna let them sort of ask their questions. The first one is Dara. Dara, would you please unmute and ask your question?
Yes, hi. Thank you for allowing me to ask my questions. I want to know, how does this initiative relate to the AUC community?
I should be answering this, actually.
Okay.
Listen, we're a center that cares about social impacts across. When you look in Egypt, for example, remember before the COVID-19, there were two major health initiatives across. The first one was a general vital signs. So you will check if somebody has a diabetes, blood pressure, etc. And I think also there was a test for the virus C. Right after it, For school children, there was something called Noor Haya. Noor is light in Arabic, Haya is life, and it was actually testing the vision of children in schools. When you look in Egypt, you have similar problems to what he was talking. There are lots of small kids in fringe communities that they cannot afford or they do not have eye vision test. And so the little one cannot actually perform in school because he cannot see or she cannot see. So a very simple prescription of glasses at a reasonable price would save the day. I'm not going to talk about cataract because cataract is a big issue in Egypt. Diabetes is a major issue. It's almost an epidemic in Egypt. So there are lots of all of those are concerns in the environment we live in. Now, when you tell me what is that related to the AUC community, I mean the AUC community, we're part of Egypt, right? And vision is a major issue. Vision is a major issue in all developing countries. Now, you had other questions, Dara. Dara? Hello? Dara, can you unmute, please?
Yes, I wanted to ask, how do you ensure sustainable responses to the elimination of blindness?
Thank you, Dara. I noticed all your questions. They're all very crucial, critical questions. And I think this is a journey that we have already had 20 years experience on. I think there's already been reference to, for example, how might we make this more financially sustainable? And I think the multi-tier system that Dr. Yeneneh described, where patients who can afford to pay will also cross-subsidize those who can't. So there's a financial sustainability issue. There is a human resource sustainability issue, which the Foundation's working hard on, but we still have a massive job to do, particularly in sub-Saharan Africa. There's an environmental sustainability component as well, which perhaps is less of a perceived priority within some African countries. On the other hand, I'm afraid that many countries, low and middle income countries, will likely bear the brunt of climate change challenges. So we are just beginning to work out as a global healthcare population what we need to do to, first of all, reduce our carbon footprint, but secondly, to mitigate our whole healthcare systems against climate change. And I think that we're getting a very acute, steep learning curve testing now on our sustainability from the COVID pandemic. Thank you.
Okay, I have another question from Nerveen El-Mashad. Nerveen, could you unmute yourself, please, and ask your question?
Hi, thank you for giving me the chance to speak. My question relates to retinopathy of prematurity. I have previously been training and worked a long time in Egypt, and I'm now currently in England, and comparing the screening program that they have here. I know that we don't have a very good one in Egypt, and I wondered if there was an experience of having a screening program as part of that initiative.
So unless Ali wants to respond to that, I just add in my my response. So thank you. Yes, a very good question. And I suppose just to let people know, as an NGO, when you devise your strategy, you can't select absolutely everything in a 4-year strategy. You have to kind of get really focused, so you move on. And you also look to where you overlap and underlap with other NGO supporting areas as well. So childhood blindness, although we've not talked about it as within this presentation as a priority, Fred Hollows has supported retinopathy of prematurity programs and training programs, the establishment of national protocols and national screening systems, for example, in Pakistan. That's been quite a big successful program there. So it is a global priority, but preventing childhood blindness in terms of the total number of years of sight saved because children live so long, if they go blind very young, then actually in the total years of sight saved, preventing sight loss in a child is second only to cataract in the total number of sight loss years experienced globally. So it very much is a priority. And I'm glad you've seen the retinopathy prematurity challenges, and we've already alluded to the fact that the Middle East region has one of the highest diabetic retinopathy rates, but it's also following on from the early US experience around retinopathy of prematurity. ROP became, again, a bit of an epidemic in the Middle East, with lots of steep learning curves there as well. So I think there is quite a lot of work going on in that area. The whole area of childhood blindness and retinopathy prematurity we haven't talked about, but the foundation does support that. And we will probably be looking to include more on childhood blindness and also on glaucoma in our next strategic 4-year period. I hope that answers your question.
Yeah. The reason I asked that question is I trained for 10 years in a tertiary center in Egypt, and through my training, and a good part of it was in pediatric clinics, I had only seen patients who were inoperable. They were so, it was so late that there was nothing to do for them, and they were bilaterally blind.
Yeah.
And there was no hint that the parents were even aware that this was a problem, that they should have done something earlier. And I think that, like you alluded to, the Pakistani and I think in South America, there is a very, very good program that is, I think, based more on the American approach of intravitreal injections, which probably works better in a country like Egypt, I think. Although even laser, we can do it. It's just there's no screening program to do it. And if you don't have a proper screening program, you're getting nowhere because you see these children too late.
No, I think you highlight the challenge that eye health has in terms of constantly trying to get into national healthcare plans. And someone else made the comment, well, why is this an important topic? And that's because blindness and the healthcare eye health interventions that we have established, cataract, treatment of ROP, diabetic retinopathy, they are all very good, have all very good health economic measures in terms of quality adjusted life years associated with them. Many more QALYs and value from those interventions than many of the other things that healthcare systems wants to prioritize. So this is a continuing advocacy battle, and I'm very happy that the Director General of the WHO and the World Health Assembly made a resolution of including, as Dr. Yeneneh said, cataract as surgery as being one of the top health UHC priorities for every national health plan, but also incorporating eye health into national eye health plans. So these things do take time, I'm afraid.
Yeah. A brief comment on this, Ali.
I have another question from, sorry, Yeneneh, you were saying something? I'm sorry.
Just a brief comment on this.
Please, go ahead.
It's relatively an advanced question. It's a very good question, but because this group is not homogeneous, from different group, ROP is on the rise, retinopathy of prematurity. As immature children, the survival of immature children increases with oxygen therapy and so on. That affects the retina, and that has caused a lot of blindness. But as you know, the leading cause of blindness in the developing nation is still cataract. But we have to choose where you focus, and our foundation has been focusing on the leading cause of blindness and visual impairment. These are cataract, trachoma, diabetic retinopathy, and URE. But I have noted that even in Ethiopia, as the oxygen therapy has raised to immature children, the ROP or retinopathy of prematurity is increasing. It's not only in Egypt; it's increasing in many nations for which there are a number of various works. Thanks.
Thank you.
Okay. I have a question from Agiro. Can you unmute yourself, please? Agiro Ayana.
Okay, thank you. First of all, thank you, Dr. Andy and Dr. Yeneneh, for your very nice presentation and a very insightful presentation, especially in line with sustainable provision of eye health service. My question is, in your presentation, you well described that in terms of in line with the current situation of COVID, the COVID situation may aggravate the previously already dry resource scarce eye health sector. So, what measures should the country take to sustainably act and sustainably providing eye health service within the limited resource for eye health? What are the possible solutions you recommend for countries? Thank you.
Dr. Yeneneh, would you like to address that question? Because it's a real problem you're having to face in the countries that you are supporting.
Yeah, just an initial reflection. You know, it is eye care issue is a really serious issue in the developing nations like Ethiopia and so on, because 90% of the blindness is occurring in the developing nation. So this is really unfair. So what I would say to organizations like us, what we need to do is advocate for the government for funding or resourcing eye health. The other one is increasing ownership and leadership. As I said earlier, the government should take ownership and leadership and don't leave eye care for NGOs and other donors. And from the donor side also, there must be some resource mobilization, because this thing is going to worsen. The health sector itself is suffering somehow, but the eye health is more suffering. So we have to carry out some advocacy works, create awareness on the burden of blindness. Like the burden of blindness in Ethiopia is 1.6%, which is over double than elsewhere. Over 1.6 million people are blind, half of which need not to be. They can see tomorrow morning if they get the required service. So the return is good. It's not an expensive surgery, even for cataract TT. They are relatively cheap, and the return for the investment is more than fourfold. So with all this, we have to do some advocacy works with the government. And this also in line with MDG. MDG also has well-stated, universal eye health. With the universal eye health, people has a right to see. Disabled people has a right to get the right service. With all this, we need to lobby and support the government and building the local capacity.
Okay. Well, I guess we have no more questions. I could ask you, did you try to work with the CSR functions of corporations? The one I have in mind actually is SLR. Now, SLR, of course, are focused on providing cheap eyeglasses. But they have a foundation, and the foundation operates separately from the company. And they actually develop almost a value chain which is separate than the regular commercial one, to provide eyeglasses to the poor. They go to as far as training the people who are going to actually administer the tests and deliver the eyeglasses from the community, from within. There are many CSR ideas, but it seems all that it's small islands all over the place, and they never coordinate together.
Yes, I'll take that. Yeneneh may have some additional comments there, but so thank you very much for bringing that up. So, I mean, absolutely, the foundation and I think most prevention of blindness NGOs do work with optical sector partners like Essilor. So we're very actively engaged with them. Another partner that Dr. Yeneneh and Ethiopia have been engaging with is called Vision Aid Overseas, which are effectively an optometry and refraction training specialist organisation based in the UK who do a lot of work there as well. So we do have very close relationships with them. We're fortunate also that in Australia we've had literally a neighbour to the Fred Hollows Foundation in Sydney and Melbourne through the Brian Holden Vision Institute, and they likewise have a kind of corporate for-profit arm, but they have a not-for-profit arm as well, a philanthropic arm as well. So we've been able to work with quite a few partners around the world to try and help these specific uncorrected refractive error challenges, as have our strategic partner, Sightsavers. So again, you mentioned the fact about collaborating and all working together, and the foundation has actually for quite some years now had a strategic partnership with the UK-based Sightsavers. So we learn from each other, and we're also in a close collaborative network also with CBM and also with Orbis too. So there is quite a bit of collaboration going on across the sector, but one of my hopes is that we actually learn from the need to have even more enhanced collaboration for us to be able to deal with the COVID pandemic. So I think there has been an acceleration of some of these needs to have partnership working. And my hope is that as a result of the pandemic and the increased collaboration amongst the IAPB, the International Association of Prevention of Blindness members, that this will help us work together with all the different partners on the prevention of blindness and visual impairment stage.
Thank you, Andy. I think we're getting closer to the end of the hour. I want to thank you both, Andy and Yeneneh, for a very insightful webinar. I also thank Maha Ouda for facilitating the process and arranging for this webinar. And it's been a pleasure. I just want to make one quick announcement. Next week, we're going to have two webinars. On Monday, we're going to have our own AUC, Jason Beckett. He's from the law department, and he's going to talk about the title of his speech is Distributed Crumbs or Demanding Bread, Sketching the Global Legal Order. I mean, obviously, from the title, he's arguing that the global international legal order is biased against the poor countries. On Wednesday, we're going to have John Ilkington. Ilkington is a major figure in the global sustainability scene. The guy is attributed to coining the expression, the triple bottom line. He has a new book, and he's going to talk about the prospects for green swan solutions and market trajectories for sustainability. He's arguing that companies could actually be a good catalyst for the market trajectories to sustainability. So the first is on Monday, the second one was on Wednesday at 7 o'clock. Thank you, and I thank the Fred Hollows Foundation, Andy Cassel, Yeneneh, and Maha. Thank you. We'll see you, inshallah, next week. Bye-bye.
Thank you very much.
Bye.
Bye, everyone.
Thank you very much.
Thank you.
Bye.